Um, well, I'm delighted to be here presenting today. As you know, my name's Sarah Stock. I'm a consultant obstetrician and a researcher at the University of Edinburgh. And it seems really only yesterday that I was standing in front of you rather nervously being voted in as a trustee to SANS. And although that doesn't seem very long ago in many ways, in many other ways, it seems like a lifetime ago. And I'm looking back with nostalgia at being able to stand in front of you and see faces rather than the reflection of my screen, and to be having some face-to-face conversations. But I am really grateful to SANS for continuing to give a good platform for research into stillbirth. And I'm very grateful for you all for staying after the AGM to hear me talk about some of the research that's going on to try and answer the questions of what does COVID infection mean for pregnant women and their babies, and what do the effects of lockdown mean for pregnant women and their babies. So in terms of the first question, which as a doctor we immediately started getting asked, what happens if a pregnant woman is infected with COVID, and what does that mean for her health and the health of the baby? And in the UK we're really very lucky to have systems set up for surveillance of obstetric complications and neonatal and child health, which have meant that they can adapt very quickly to collecting data and researching the effects of COVID infection. Most of these are based on women who test positive, obstetric surveillance systems where women are admitted to hospital, or where there's a strong suspicion of COVID infection and symptoms of COVID in the pan-COVID study in the community, as well as surveillance of babies admitted to neonatal units. And these studies have been really valuable, as Claire outlined, in giving us initial results as to what COVID means and how it affects pregnant women. I'm also really, really proud that in the UK that we're leading the way in treatment studies, and pregnant women are not excluded from these studies. And that's really unusual, and it's really, really important that pregnant women are not automatically excluded of new treatment developments and evaluating existing treatments to ensure that they will be eligible to receive treatments if they become seriously unwell with COVID. And as we go forward, it's going to be the importance of recognising the need to include pregnant women and their babies in vaccination studies as these develop. But most of these studies that I'm talking about are about women with COVID and the severe end of the spectrum. And of course, as this pandemic develops, we're learning that you can have COVID without symptoms, that many people have not, particularly in the beginning, did not have access to tests. Only the most severely affected were tested. And there's a real need to understand the epidemiology of COVID in pregnancy. That means how it's affecting everybody, and particularly to understand, as Claire outlined earlier, whether there are specific groups that are more vulnerable and what we can do to recognise that risk and mitigate that risk. So in Scotland, we're doing COVID in pregnancy in Scotland. This is a study with Public Health Scotland, and it's a population study. And what's really exciting about this is we're linking GP records from everybody in Scotland. So this is part of a wider study called EVE2, but we're focusing very much on the effects on pregnant women and their babies within COPS. And for the first time, we're going to be able to get information about all stages of pregnancy. So we're being ambitious and want to include all women who've had a pregnancy or were pregnant at the start of the pandemic. The 1st of March was the first case in Scotland, was recognised. And in real time, collecting data on everyone who was pregnant, whether they were just about to give birth on the 1st of March or whether they became pregnant on the 2nd of March, will be included in this study. We're linking the GP records to maternity records, neonatal records, and other hospital records, but importantly to records from NHS 24 and COVID assessment hubs, where women were advised to phone and seek advice if they display symptoms of COVID. Also, COVID test results, so we're linking to the databases of all COVID test results, and indeed we'll be able to link to serology, so retrospectively using blood tests taken in pregnancy to see who has antibodies for COVID. And within this way, we're going to be able to, at population level, describe how many pregnant women had COVID, whether they're more vulnerable, and which groups are particularly more vulnerable, and really importantly for us, concentrating on the outcomes of miscarriage, congenital anomaly, stillbirth, preterm birth, and neonatal infection and neonatal death. So seeing right across pregnancy whether the virus can affect pregnancy outcomes and at a population level, and these are the kind of numbers of people that we need to be looking at to really detect these differences. In terms of the data, the data set is now assembled from March until June, and we'll be hopefully publishing these data and publishing them in the public domain quickly, hopefully before the end of the year, if not very early next year, and then we'll be adding to these month on month so that we can be sharing these figures with the public and policymakers so that we can be acting on these. There's a little QR code here. I don't know if anyone's able to access this, but a little plug here. We are recruiting parent members to be involved in all areas of the research. This is the bigger research study, EVE2, but COPS is a really important part of that, and we really want parent voices to be involved in the advisory committee. So that is, there's an open call for for patient and parent members at the moment, and I'll put this slide up at the end if in case anybody's interested or can share that on social media. So that's research on the infection, but of course there's also the question of what is lockdown doing to perinatal outcomes, and again Claire has given an introduction to our current knowledge on that at the moment. And what's one of the interesting things is really quite early at the stages of lockdown, there became these headlines starting coming out, and this question of, was there actually a really unexpected reduction in preterm birth associated with lockdown? And to give you some of the data, this is the scientific papers that have come out about these, and these are just a few of these. One of the first was from Ireland, suggesting that in these sort of very low birth weights, so these are very small and thought to be very early births, there was a 73% reduction in births and associated with lockdown, which they termed a sort of natural experiment. In Denmark, that followed a 90% reduction in extremely preterm births in association with lockdown. This is a study from the Netherlands, again showing, this is just in live-born babies, up to about a quarter reduction in preterm birth. And then a different story from a different part of the world, a study in Nepal, where we saw that there was an increase in preterm birth and potentially an increase in stillbirth seen in this setting. And this led us to think a little bit more about these data. And it is a really interesting finding, because these are dramatic reductions in preterm birth. And of course, we know preterm birth is the biggest driver of neonatal mortality and actually mortality under 5s on a global scale. But if we look at these data, they're important, and it's important to get out quickly, but we recognize that they're not population representative. They represent perhaps individual institutions, and maybe they reflect that preterm women who had preterm labour couldn't access those institutions or went to other institutions. Really importantly, they didn't take into account stillbirth. And so there's a question, were these babies not being delivered in time? Were they actually babies that a problem could have been recognised, they could have been delivered preterm, and actually by not doing that, they may have been stillbirths. And if you don't look at perinatal outcomes as a whole, we could miss that. They're often single centre or single country, and it's difficult to do comparisons and really know what's going on with those kind of data. And of course, there are none at this stage exploring mechanisms. And the observation that there's different stories and different patterns and different income settings was also something that seemed really striking. And these observations were the founding ideas for the IPOP study, the International Perinatal Outcomes Study in the Pandemic, a new study of which I'm one of the co-leads on. So what is happening with stillbirth? Well, along with the headlines about preterm birth, there have been headlines about stillbirth as well. And it's really difficult to know at the moment, as Clea alluded to, exactly what's happening. I am going to draw your attention to some data from Scotland. Again, another QR code in the corner here if you want to find this, and the website down the bottom here. But this is a really, really valuable resource run by Public Health Scotland, and they are publishing data on stillbirths, on neonatal deaths and perinatal mortality on a dashboard, a wider impacts dashboard. So these data are coming up in real time so that we can see in the public domain what's happening to stillbirths, and Scotland's one of the only countries that's making this data available. You can see, as expected here, with stillbirth, the numbers fluctuate around the average by chance, which is what we would expect to see, this blue line here. And really, so far, there's no clear pattern of any change in stillbirth rates in association with the pandemic, with this summary data, broad summary data, which is being monitored by Scottish Government to see if there are trends that we should be investigating. But reassuringly, at the moment, there is no evidence of change in stillbirth rates consistently with pandemics, although further research is being done. And these numbers are from one country. Importantly, we've got to put these together with other countries' data and quickly to be able to see exactly what's happening with stillbirth. And that's what we're doing with IPOP. So we're saying, is there a reduction in stillbirth? Is it really happening? And if it is happening everywhere? If it is happening, why is it happening? And are all pregnant women affected the same way? So is it plausible that there's a reduction in preterm birth or changes in stillbirth? And the answer is yes, it is plausible. And these are some of the sort of hypotheses that we have of why things might be happening like this. There might be a reduction in stress, not necessarily for everyone, but for some people they have found that working from home or spending more time at home with the family, it leads to a reduction in stress. Really importantly, there's been an increase in hygiene, and we're seeing a reduction in other kinds of infections. Infections are associated with preterm birth. Is this due to a reduction in infections, therefore leading to a reduction in pregnancy complications? There's been a massive reduction in air pollution in some places, and again, this is another potential mechanism that we can use lockdown to explore the effects of air pollution on pregnancy outcomes. And of course, with changes in maternity care, is it actually a decrease in interventions that leading to a decrease in preterm birth? And if so, we need to know whether that's a good thing or a bad thing and be able to quantify that. There are, of course, we might find the alternative that perinatal outcomes are negatively affected by the pandemic in some situations. What could lead to them? An increase in stress. We know that there's fear, anxiety, unemployment, stress from homeschooling could all increase the potential for preterm birth or stillbirth. Nutrition, the arrow here goes either way. From my own N of 1 experiment in lockdown, I can say I'm veering towards overnutrition, I think. But of course, we recognise that in some settings and for some people that with a lack of choice there, poverty is leading to undernutrition. And there's been big changes in maternity care and how women access maternity care, women's behaviours, messaging, and also how maternity care is delivered. And that's really striking, actually, on a global level. Some quite incredible, hard stories coming out of low and middle income countries. And And so all of these factors we need to study in relation to perinatal outcomes. We're going to look at aggregate data, so summary data, and be able to examine these factors from a wealth of different data sources, starting off with summary data, but eventually moving into the individual level data where we can start to think about factors such as employment, maternity leave, race, and other comorbidities, as well as COVID infection itself. I'm aware of time here, so I'm going to skip through these a little bit quickly so that we can get time for some questions at the end, if that's all right. But our aim is to investigate the impact of the COVID-19 pandemic on perinatal outcomes worldwide and identify the mechanisms, not just for understanding this, but to see if we can find discoveries and translate these into management changes, to translate these into policy, so that we can understand better what causes, what can influence preterm birth and stillbirth, and find new ways of trying to prevent them. And we really do feel that the global collaboration here is really important. Our approaches are very multidisciplinary. We have core philosophies of equity, collaboration, and open science, and have developed tools and are really working hard on making this as open a project as possible. And we have strategic partnerships, both with parent organisations as well as platforms to allow big data analysis. And we have continuous stakeholder engagement, recognising the importance of parent voices within this collaboration. A map showing, at the moment, we're at 100 collaborators in 42 countries committed to contributing data to the study and the different aims that we have. Firstly, to describe trends, then to address the context and the mechanisms, and further investigations of those mechanisms so that we can change practice and policy. It's supported by this International COVID Data Alliance, a new alliance which is working in different fields, and we're really pleased that we've been chosen as a driver project for this. And that's giving a really world-wide platform. And what's really important here is that stillbirth, preterm birth, neonatal death, perinatal outcomes are one of two lead projects for this. One of the driver projects in the Data Alliance is about treatments for COVID, and the other is about pregnancy and babies, which is us, and so we're really fortunate to do that, and it's giving a really good platform to show the importance of research into health in this area. So I'm just going to skip to the team just to say thank you to them, because I'm one of the 5 co-leads and a manager here. You can see that we span literally A to Z in names. We also span time zones of 18 hours, so there is quite literally someone working on this round the clock, and it means that it's a very fast moving collaboration and really something exciting to be part of. I'm also just going to say thank you in COPS to Public Health Scotland, particularly Dr. Rachel Wood, who's really leading on this idea of making data publicly available as quickly as possible, and led sort of some of the wider impact work of the Scottish data that I can show you. And also Professor Aziz Sheikh, who leads a huge portfolio of work and is very influential in COVID work, but has really listened to us when we've said the importance that pregnant women and their babies require to be included in this research, and he is now really leading that shout as well, and making sure that that we look at these outcomes properly and there's inclusion of them in wider portfolios of work going on in the UK. And thank you also to SANS for giving me the opportunity to talk today, but also their support of this work, stakeholder involvement, and the language to ensure that we have a voice on this big and busy field of COVID research, and all the funders contributing down below as well. I'm going to stop for questions now, and we'll just leave this screen up there with the QR code saying we are recruiting parent members. We always have a need for parent members and parent voices in our research, and so if you would like to be involved, please do follow this link or contact me directly if you're interested. Thank you very much indeed.